I see that we are at the top of the hour, and so good afternoon, everyone, and thank you for joining us again for the Superior Health Quality Alliance Roundtable conversation. My name is Jerry Henniker, and I'm joined again by my colleagues, Kelsey Ostergen and Kim Heft. For those of you who have joined us before for these meetings, we're glad to have you back. And then also, if this is your first time attending one of these sessions, we're so glad you've joined us for the first time. Just a reminder, these sessions are now going to be occurring twice a month, beginning in January 2023. The sessions will at that time be the second and fourth Wednesday of each month. So a little bit more regular schedule with the twice a month schedule. Each session will continue to consist of about 30 minutes of education and where we highlight topics that are important to you and the work that you do. And then we will also make sure that we're including information about the COVID-19 vaccinations and boosters. Following our presentations each week, we will also have 30 minutes or so set aside for discussion and Q&A. I wanted to let everybody know that at the end of the slide deck for today, there is information to make sure that you can register for the sessions in 2023. You'll need to re-register for those sessions. We're hoping that you come back and join us again for all these sessions in 2023. We love having you. One of the things as you listen to our presentation today, we'd ask you to think about any pebbles in your shoes or things that you're struggling with, or just things that you're trying to figure out. It doesn't have to be about our topic for today. It can be about other things. You can send me those questions in chat via the Zoom chat. We've got a couple different input this way for upcoming sessions, so we love to hear from you about things that you want to learn more about. Also, please feel free to put any questions or comments during today's session in the chat box. We will have time, as I said, at the end of our presentation for discussion and to answer those chat questions. Also, towards the end of our session today, Kelsey will put a link in chat for the evaluation. We love to hear your input. This is how we know what sessions you want to hear more about, but also, are these sessions working? Because we want to know, of course, if they are, but if there's something that we can change, we want to hear about that too. So please take time to answer that evaluation. Kelsey will also put a link to the PDF of the PowerPoint for today so that you have the slide and presentation for today. One of the things just here quickly before we get started, as I said, we've got a lot of great presentations planned for 2023, but we also want to know what you want to learn more about. So we're going to have, Kelsey's going to launch a poll question now so that we can get some feedback to find out what it is that you want to learn more about in the coming year. And Kelsey, I'm not sure. I'm maybe not seeing the poll, so hopefully the poll was launched. Can others see the polls, or just me that's not seeing the poll?
Jerry, the poll is up and we are getting responses.
Okay. Thank you, Kelsey. And Kelsey or Kim, if you can just let me know when you're ready to close the poll.
We'll give it about 10 more seconds and then I can close out.
Okay. And thank you for everybody for taking the time to respond. Okay. And I think we've got enough feedback, Kim and Kelsey.
Yes, we sure do.
Thank you both for letting me know. So we'll get that closed out. Thank everyone for taking the time and to answer us. And again, if you think of something today that you didn't have a chance to put into the poll, you can certainly add it in chat, or you can even put it on the evaluation at the end of the session. So I just, go ahead, Kim.
Jerry, just real quick.
Sure.
As everyone can see the poll here, and we have infection control came in with a whopping 89% want to hear more about infection control practices, processes. If you could, when that topic came up, drop in chat in particular, what are you thinking? Give us a couple of topics. 8 out of 9 of you indicated that this is something you want to hear more about. In what area would be great? So if you could give us a little more feedback. Thank you. Thanks, Jerry.
Oh, thanks, Kim. No, thanks for explaining that. Like I said, I'm not sure why it's not showing in my screen. So, well, with that, I am happy to introduce you to our presenter for today, Josh Swire, and Josh will be presenting on recognition and management of sepsis in the long-term care setting. And with that, I'm going to turn it over to you, Josh.
Great, thanks, Jerry, and good afternoon, everybody. My name is Josh Swire, and I'm a Quality Improvement Advisor here at Superior Health Quality Alliance. And I think the topic of sepsis is really a good, it's a good linkage to our COVID-19 work. As severe sepsis is honestly the most common complication observed in COVID-19 patients, and hospitalized COVID patients are 4 times more likely to develop septic shock than those hospitalized with pneumonia or influenza. So we will go through a few things today. If we could advance to the next slide, please. Our objectives are to define sepsis and its impact on our communities and health systems. We'll outline early identification strategies, review sepsis best practices specifically aimed at long-term care and skilled nursing facilities. We will review a sepsis case study utilizing the nursing home sepsis screening tool that Superior Health developed specifically for skilled nursing facilities and long-term care. Looks like that advanced by itself. We can go back. I know these slides for some reason are timed, so and then we'll discuss next steps that you can go ahead and take to your leadership team and your medical director to get your sepsis program off the ground or perfected. You might already have a sepsis program that's implemented, and maybe it's time to just take a look at that program and analyze, you know, what's working well, what can we improve on. Next slide, please. So we'll start by just identifying and outlining what is sepsis. You know, here's the long definition: that it's a life-threatening condition that arises when the body's response to an infection injures its own tissues. Essentially, it means that a localized infection has entered the bloodstream and is starting to enter organs, which can cause organ dysfunction. And if left untreated, it can result in permanent organ dysfunction or even death. Previous slide, please. And sepsis is the leading cause of death and healthcare spending globally, both for admissions and readmissions. Next slide. So this is a little infographic from the CDC, and it just kind of outlines the idiopathic way that sepsis can start and really spread through the body. And 80% of sepsis begins outside of the hospital, which I think is really good information for our long-term care and SNF partners to recognize that, you know, typically by the time they hit the emergency department, and if they are septic, they could be in more advanced stages of sepsis. So really early recognition, early collaboration with your physician regarding residence status, and early interventions are going to be the best things that we can do to not only identify sepsis early, prevent it from going into septic shock, but also decrease mortalities and decrease hospital readmissions. 7 out of 10 patients with sepsis had recently used health services or had a chronic diagnosis requiring frequent care. So again, you know, also pointing to the evidence that nosocomial infections or infections, you know, that arise from the healthcare setting are very prevalent in the total amount of sepsis cases that we see. And looking at the right at the infographic, these are the body systems that are the most common infections that can lead to sepsis. The first being lungs, such as pneumonia, which again is very important when we start talking about vaccinations and COVID-19 and getting your pneumococcal vaccinations and influenza. That really is the primary organ that sepsis can result from. Urinary tract infections, gastro infections, and skin infections. Next slide, please. Sepsis is the #1 cost of hospitalization in the United States, and this number, it kind of blows me away just because it's went up exponentially in the last few years. I've been giving sepsis presentations for almost, I don't know, around 8 years. I used to be a sepsis coordinator in the hospital, and this number was around 30 billion, not even 6 years ago. So we're talking about almost a double increase in healthcare spending just in the last decade. But costs for acute care sepsis hospitalization and skilled nursing care combined are estimated to be around $62 billion annually, which is double the average cost per stay across all other conditions. And it's the leading cause for hospital readmissions, costing more than $3.5 billion each year. But despite all of this, a large percentage of American adults still have never even heard of the term sepsis. Next slide. So considerations for the elderly, a lot of this is going to be merely, a refresher, but we know that the elderly constitute 1/5 of the US population, but 2/3 of the patients admitted to the hospital with sepsis. And they have a lot of, risk factors and comorbid conditions, such as they're prone to urinary tract infections, which we know is a common source, malnutrition, increased incidence of colonization by drug resistance bacteria, and of course, declining immune functionality, which makes them more susceptible to infections. Next slide, please. So this is an info or a graph that the data is a little old. It is from 2008. We couldn't really find a bunch of new data on this, but it's still very prevalent when we pulled our claims data and looked at admissions and readmissions compared to age. But this graph looks at the hospitalization rates for sepsis or septicemia. It compares it against male, female, and age. And as you can see, there is not a real big statistically significant difference between males and females having a prevalence of sepsis. But as you can see, the older we get, the higher rate of sepsis or the higher probability of getting sepsis there is. So as you can see, comparing 65 to 74 and skipping to 85 and older, it's almost a threefold increase in getting sepsis. So just some more information. It's really making a case for why this is so important when working with our residents. And we can, if you're interested in getting more of this information, the slides are posted, but we can see about what other information that you might need to present to your leadership team or your medical director to really get that buy-in that this really is not only a health priority, but a strategic priority. Next slide, please. We know that the elderly are more likely to be admitted to the ICU, and they have the highest mortality rate in the old elderly, which are 85 plus, longer hospitalizations, more prevalence in post-sepsis impacts, specifically around post-sepsis syndrome, which 5-year survival rate, much like even cancers, having severe sepsis it's frightening when you look at the 5-year survival rates and even the 6-month survival rates. Somewhere around mortalities in the 6 months, different studies will say between 10 and 30%, which is very high. It contributes to cognitive decline as well as physical long-term disabilities for ADLs and IADLs. Next slide, please. So when we're talking about sepsis, there really is 4 buckets or categories that a person could advance through, starting with the first, which is just a basic infection. There's that long, definition. I think we all know, infection is, a foreign body, whether it be viral, whether it be bacterial, whether it be fungal, has entered the body and it's become potentially harmful. Now left untreated, and once that localized infection starts to spread, we go into sepsis. And sepsis is when we have a known or suspected infection plus 2 or more SIRS criteria. Now that SIRS stands for Systemic Inflammatory Response Syndrome, and I'm going to talk about this more on the next slide. And we also have a case study that we'll be going through. So that's may not be the first time you've heard the term, but if it is, do know we will be going through that a little more. And then sepsis can advance to severe sepsis if you have that infection, plus 2 or more SIRS, plus a new organ dysfunction. So now, not only has it entered the bloodstream, but it has now entered a vital organ and is causing some sort of organ dysfunction. And septic shock is when we have all those things for severe sepsis, and we draw lactic acid, and either it's greater than 4, indicating we have, potential tissue destruction and our lactic acids are high, or our blood pressure starts to really tank. And that's as evidenced by a systolic blood pressure less than 90 or a 40-point drop from their baseline. Now, there is some other criteria for the hospitals. This is probably already a lot of information, so we did keep out things like mean arterial pressure and all of that. For the sake of this presentation, we are going to define hypotension as systolic less than 90 or a 40-point drop from their baseline. Now, to hit septic shock, there's really only two ways to hit septic shock. Either one, you draw that lactic acid and it comes back at 4, and they have severe sepsis, bam, they're in septic shock. That qualifies them for septic shock. Now, or if they receive a 30 milliliter per kilogram fluid bolus, following the bolus, if they're still hypotensive, they qualify for septic shock. Again, I'm gonna say this 2, 3, 4 times throughout the next 20 minutes. So just stay with me. Next slide, please. Okay, this is kind of I guess more of a visual way to outline the 4 things that we have. On the left, we have the SIRS criteria, which I told you is the systemic inflammatory response. And these are the CMS defined SIRS criteria. So attempt greater than 100.4 or less than 96.8, heart rate greater than 90, RESPs greater than 20, white blood cell greater than 12 or less than 4, or greater than 10% neutrophils, altered mental status, and that should say outside of baseline, or a blood glucose greater than 140 and a non-diabetic. Again, that blood glucose typically is used more so in the hospital setting, but it is considered a SIRS criteria. So once you have 2 or more of those SIRS criteria in the left-hand bucket, plus you see the green arrow pointing up there, systemic manifestations of infection, that can be a suspicion. That doesn't mean that you have a blood culture back that's positive. That doesn't mean that you have a wound that has copious amount of pus and it's red and inflamed, and it could be a suspicion of infection, which I think makes sepsis, it makes it a little more subjective based on a nursing assessment. And we always tell people to lean towards the side of caution. Have they recently been in the hospital? Are there other signs of infection? And being pretty proactive and liberal on that side. And honestly, if there's 2 or 3 SIRS and you just have a gut feeling and, putting that, yes, there is a clinical suspicion, even though I don't have a confirmed infection. And once we advance into actual sepsis, this is when those systemic magnification of infection, we also have a confirmed infection at that point. And severe sepsis is when we actually have those signs of organ dysfunction, hypoperfusion, or hypotension. And I'm going to go over those body systems, the cardiovascular, renal, et cetera, here in the next couple slides. Next slide, please. So what are some basic things that we can do to prevent sepsis? Obviously, the number one hand hygiene prevention tactic or prevention best practices is hand hygiene. Oral care, we actually developed this as a kind of a quick 30-minute presentation, but this sepsis was actually a 3-part class, and we did a whole 90-minute session on oral care and pneumonia prevention, recognizing that the respiratory system is actually exposed to environmental pathogens more than your skin. It is actually internal. So recognizing that oral care and pneumonia prevention is huge. Wound and skin care, very big in long-term care and skilled nursing facilities. Catheter care and urinary care. And of course, one of the biggest things that we can do that's really not that, as difficult as some of these more advanced things is getting vaccinated. Getting our older folks their pneumococcal vaccines, their COVID-19 vaccines, and their prevention of viral sepsis. Screening and early identification really is the key of this presentation. How do we, as soon as possible, recognize that a resident might be starting to show signs and symptoms of sepsis? And studies show that the earlier that you get the early goal-directed interventions on board, which are these things here: source control, obtaining blood cultures, getting those antibiotics on board. the earlier you do those interventions, the better the outcomes hour by hour. There's several studies out there, and this may not be the first time you've heard this, but for every hour that you wait for antibiotics or fluids, once you've identified a patient is in severe sepsis or septic shock, their chance of mortality increases between 5 and 9%. So that's pretty significant. I mean, even at let's say 9%, that's essentially within 11 hours, a pretty good indicator of mortality if left untreated. And we're going to discuss protocols, when to send your residents for acute treatment versus what can be done in your facility. This is probably going to be one of the biggest barriers, that when we talk about implementation is, can we do a bolus? Do we have on-site lab? Does our lab let us order stat labs? We've talked to long-term care and skilled nursing facilities that say, yeah, we don't have lab on site, and lab is so understaffed that if we do a stat, we have to send them to ER, which we also recognize is kind of the opposite of what we want to do, right? We just don't want to send people to ER just to get a stat lab. So really thinking strategically about what processes and what resources do we have internally and being realistic about it. Next slide, please. So there's three things that we really get out of today's discussion. One, early identification, assess, assess, assess. We have developed a screening tool that you can use. You can rebrand it, take the Superior Health logo off it, put your own logo on it, build it into your electronic health record. It's yours. But we can't identify if we don't do frequent and best practice assessments. Two, get those antibiotics on board ASAP. It says 1 hour, but really it's ASAP. If we know that a patient has a known or suspected infection and 2 or more SIRS criteria, and they're starting to show a sign of organ dysfunction, I mean, we'll call the physician and do our SBAR and get recommendations, but we should have some sort of a protocol that our nurses know and should be flagging. We're thinking this patient is starting to get septic. So early antibiotics and early fluid resuscitation. Once the patient their blood pressure starts bottoming out, or their lactic acid is above 4, that's where we need to decide, do we ship the patient out, or do we have a protocol where we can start fluids in-house? Next slide, please. So this is just a quick little snippet of the sepsis screening tool. Actually, I'll have you go right to the next slide because I believe I go section by section here. So yeah, this is section 1 and 2. And the first section is, are there 1 or more or 2 or more of the following? So temp greater than 100.4, less than 96.8, respiratory rate, heart rate, whites, ultra-Del OC. So if you do this check and there is 2 or more, you advance to section 2. If there is less than 2, you can stop the assessment, they screen negative. Okay, and we do recommend that this screening tool be done upon admission to your facility with any new or suspected infection or any new order for an antibiotic or antiviral, or a change in any condition. So let's say that a patient or a resident has 2 or more, we would check yes, 2. On to the next section. Is there more of the following signs or symptoms present? Now, this is again where it's very subjective. Clinical suspicion of infection. As a nurse, I might say, oh, they have a wound and it looks a little red, it's a little tender to the touch. I would instantly say yes. If they got 2 SIRS, they have a wound that's tender to the touch and it's red. Again, being liberal and erring on the side of caution is probably the best. But if the answer is no, then you would stop there. So if they have 2 SIRS and no clinical suspicion of infection, or they're not on antibiotic therapy, we should still probably notify the doctor because there's probably some other condition going on, unless it's completely incidental. Maybe they just got up for therapy and their respiratory rate and their heart rate's up. We also got to use some clinical judgment. Lots of false positives happen in the emergency department with people that are having anxiety attacks, panic attacks, even myocardial infarctions, because they're going to mimic these SIRS. And that's why that clinical suspicion of infection really is a key part in this. Next slide, please. So if we say yes to section 1 and 2, section 2, It looks like that was repeated. So section 2, we follow the action steps at the bottom. So that is, we're going to check their pulse ox. We're going to look for signs of severe sepsis, such as dehydration, pretty much do a full physical assessment. And I'm sure most of you folks have a either assessment form on paper or it's built into your EMR. So it should trigger a full physical from the RN. And then at this point, follow your facility's policy and procedure regarding potential resident transfer. So this is where we don't have the answer, right? Because we don't know each facility's unique services that they offer, their comfort level. Some are fine doing a 30 ml per kilo fluid bolus and monitoring and have more slightly acute units that they can do that. And some say absolutely not. We don't have the capacity to do that. We got to ship them out. That is going to be based on the procedure based on your facility. Next slide, please. So here's a little case study. So we will fill out one of these together. Mr. John Smith lives at Superior Health Care Facility and has been struggling with severe dementia and chronic cardiac disease. About 2 weeks ago, he had a case of pneumonia and was admitted to the hospital from December 13th through the 19th and has returned home to your facility. Next slide. So we received a report and we have our assessment findings. 88-year-old male admitted back from a 5-day hospital stay related to pneumonia, history of dementia, heart failure, hypertension, pneumonia, and UTIs in the past few months. Here's his vitals: 98 over 58, heart rate 112, respiratory rate 28, temp 99.8, SaO2 89% in room air, cap refill is less than 3 seconds. He has a cough, he's not on long-term oxygen, he's still on oral antibiotics from his hospital stay, and the family reports that he's more restless, especially since his pneumonia diagnosis, and he hasn't been eating as much. His catheter is draining a small amount of dark urine, and we don't know if his confusion has increased because he has a strong baseline dementia diagnosis. Next slide, please. Okay, so go ahead and this is an interactive one, so I need you to click the space bar. Okay, so the first question is, are one or more of the following present? Well, the answer is going to be yes. We know because he's already on antibiotics. He's still on oral antibiotics from his hospital stay. Even if he was not on antibiotics, knowing that he was just hospitalized and he has a cough, again, still using that nursing clinical judgment to say, something in my gut saying that there could still be an infection in there. There's a clinical suspicion. I would still check yes. So now that we've checked yes, we can go to section 2. Do we have 2 or more of the following SIRS criteria? We know that he does not have a fever. He's at 98.6, I believe I read, but he is not at 100.4. Is his heart rate greater than 90? Yes, it is. I believe it was 112. So we got 1 yes. Respiratory rate greater than 22? Yes, it was. It was over 20. Systolic blood pressure less than 100? Yes, it was, I believe. I think it was 98. And then new onset mental status changes, mild confusion or disorientation. I believe we put no on this because we were not able to verify whether that was related to his baseline dementia or not. Either way, we now have 2 or more SIRS criteria. We actually have 3. So that's going to put us to the next section, which we'll do, in spacebar. So now that he's had 2 or more SIRS plus clinical confirmation of infection, he is positive for possible sepsis. So we should do these action items. We're going to check his pulse ox, which we already did. We're going to review the advanced directives and his code status because we should know that, knowing that there's the potential that there could be a fast health decline. And then we will proceed to section 3 to assess for severe sepsis. Renal dysfunction. Yes, we saw that he has a catheter in and it's small, draining small amounts of very dark urine. So we would flag that as a yes. Cardiovascular dysfunction. I believe we put no on this because his blood pressure is less than 100, but it's not less than 90. So we remember that systolic less than 90 is really when we start to recognize they are having hemodynamic instability, and we need to probably address that with fluids. but no, his cardiovascular system is not positive. Respiratory dysfunction is. He was, I believe, 89% on room air, so he was less than 90. Neurologic dysfunction, again, no, because we cannot confirm that. Perfusion dysfunction, I believe, was a no. So we do now have 2 organ dysfunctions that test positive, and you only need 1. So go ahead and proceed to the next slide. So now we're positive for severe sepsis. And once we're positive for severe sepsis, we kind of stop, because there is another category called septic shock. But again, for the skilled nursing facility and long-term care, at this point, you're about maxed out on acuity that you could probably do. I know that you're not going to insert central lines and start vasopressors and hook them up to central venous monitoring and all that. So we tried to make this as simple as possible and remove a lot of those hospital interventions and get it down to 3. 1, call the doctor. He's, patient has possible severe sepsis. Here's what we find. Do your SBAR. Notify the resident's representative of the situation and need for transport if necessary. Again, that is going to be based on your facility's protocol on when you ship a patient out and what you can do in-house. If you can do those boluses in-house, great. If you can do the antibiotic in-house, even better. And discuss those positive findings and potential interventions with the physician, the bolus, the antibiotics. What kind of labs can we get? They should probably be stacked, because we do need to get that lactic acid on pretty quick. And we want to know if that's greater than 4, chances are they're probably got to go to the hospital. Again, including resident representative or decision maker, knowing that code status, and knowing the transfer protocol. Next slide, please. Okay, this is my last slide, and then we'll open it up for questions. This is just something for you folks to be able to use to take back to either your medical director, or if you have a QAPI team or a quality director that you want to get these conversations going. These are just steps that you can put into an action plan on what you can do to get this program off the ground. 1, getting that team together to create an early recognition process. And that's, in a way, that's been done for you, as in the tool is done. So take it, use it, please. You can get your medical staff support for screening and early interventions. And, some medical directors or medical staff, are comfortable with some nurse-initiated orders, letting nurses order a stat lactic acid, or if there's a certain antibiotic that they like to use, like Rocephin, I know that IM Rocephin is fairly popular, they want to start with that. We have found that nurse-driven sepsis protocols, they work, and they're faster than calling a physician, giving report, waiting for an order. Developing the screening tool process, maybe building it into your EHR, and defining with your staff, when are we going to be doing this? And again, we would recommend on admission with any change in condition or with any new or known infection. Define staff education and content. We have some good educational materials here at Superior Health. So if that's something that you would like more of, please let us know and connect, email me, email any, Kim or Kelsey. And if we don't have something, there is the possibility that we can add it to the docket to create something. Prioritize sepsis as a performance improvement project with oversight by the QAPI committee, and of course, surveyors love that, right? Like, we recognize that this is the #1 cause of admissions and readmissions and mortality, and having that QAPI project during some sort of an audit just shows your commitment to quality and excellence. Evaluating your screenings, whether that looks like pulling 10 or 20 charts a month and just seeing if they were done on new antibiotics, were they done on admission, et cetera, and then developing an ongoing sustainability plan to really hardwire that and essentially turn that into just like your admission assessment. I mean, it's probably very rare that a resident misses an admission assessment, and getting to the point to where all staff are so accustomed with that it's just a process that everyone's used to doing. Next slide, please. Well, here's my contact information. I'm going to open it up to the floor for questions, or hand it back over to Kim, to maybe Kim and Jerry to maybe moderate the questions. But Yep, you'll have my contact information. I'm happy to help in any way, and learn about the different barriers and things that you have and how we might be able to help. And we also very likely will be having future sepsis, what we call affinity groups or structured collaboratives, where these educational offerings are spread over 2 to 3 months with actionable items that you can do in between meetings, if you want to truly identify this as a coffee project. So with that, I'll open up the floor and hand it back over to Jerry and Kim.
Thank you, Josh. That was a wonderful presentation. And I'm just going to check in with Kim, see if we have any questions in chat to start with. We'll get those answered first.
No, Jerry, I don't see any questions right now in chat. But thank you, Josh, first off, it was a really good presentation. And the tool that you used is also, it's a really very well made, easy to read and useful tool. So for those that would like to get a copy of that, if you give me a second, or maybe even Kelsey could go in, and I know, but I see the resource slide here, but is it, I don't think that tool is in here. Is it, Josh?
The tool it's on the website under, I think it's under infection control and prevention. Yeah.
That's okay. How about, like, maybe I could get Kelsey or we'll look at this. Elena Bear, one of our colleagues, looks like she already has the link for that tool in chat. So that's awesome. Because I do like that tool a lot. If anyone has any questions for Josh, please unmute yourself. Put your questions in chat, whatever is easiest for you. And I'd also like to know is, after you've heard this presentation from Josh, audience, how are you feeling after you heard this? Are you feeling like your sepsis protocol is like, you heard this and you said, hey, we're doing our best. I am glad Josh did this because I know we're doing well? Or do you feel there might be some areas that you could improve on? And if so, where do you think what kind of barriers are you having with your sepsis protocol? That might be really useful to all of us, because if you're having a barrier with your sepsis program, I bet you someone else is. And maybe we could talk through that and figure out some strategies to improve it. Anybody have any barriers?
Yeah, specifically, I'd like to hear around availability of lab services, availability of medication backup boxes. Do you have availability of broad spectrum antibiotics, either IV, IM, that's in maybe your med room? These are just barriers, having worked with various nursing homes across our 3 states, that we've learned. Or even the fluid bolus can be challenging, because it's a lot of fluid, especially if you get an obese resident. You're talking, it can go up to 4, 5, 6 liters. And a lot of folks are not comfortable infusing that much fluid in a non-acute care setting. So yeah, just kind of curious as to specifically those processes, which we found have historically been barriers. I also find that, a lot of the barriers tend to be in the standalone facilities, those not connected to a hospital, or those that are rural and a hospital is quite a bit away, which are obviously is going to look like a very different intervention than a nursing home or long-term care facility that's connected right to a hospital, and they can just transfer right to ER, or they can have their lab come and just draw. It's very unique One size does not fit all with sepsis, that is for sure.
You know, I'm wondering too for the group, not to, I know we're still kind of waiting to hear back if people have barriers, but kind of tied to that after the presentation today, you know, thinking about what barriers you might have in your facility, what are some of your next steps that you might want to take after hearing this presentation today? What are some things that you can do, you know, in the next week or so using what you've learned?
We do have a comment here in, oh, hang on just one second, from Sarah. Sarah says we lack the ability to run any IV medications due to the RN versus LPN on staff. Labs are based on who is available to run them, 30 minutes to the closest lab for processing. Josh, are these the type of things you've heard in your practice?
Yes, the LPNRN thing is a barrier, and I'm not going to give any solutions that are borderline, probably not the best solution, but I did hear one that was semi-creative. I don't know how I felt about it, but LPNs, at least in Michigan, can hang piggybacks. They can't start an IV, they can't do a primary line. So I know of some facilities that will allow it out, that they will set up like a crystalloid bolus, normal saline lactated ringers at like KBO or 50 mLs per hour, and allow the LPN to piggyback the antibiotic. Now again, I'm not saying that that's the right thing to do, but I think technically, but yes. And again, that's why it's so specific to your organization, because I think somebody just put, if there's only LPNs there and there's nobody to change the primary bag, that's a bigger problem. A lot of places, some places I talk to have like one RN on staff all the time, but it's a larger facility. So they'll allow the LPNs to do the piggyback, but the the supervisor has to come and do the primary bag. But if smaller facilities that even have only LPNs, that's not a solution either. And the other thing is, discussing whether the pros and cons of an IM injection, whether it's, just something to get them started. If you're going to transfer them, you want to give them a granule of Cephin IM or something, based on the physician's recommendation, that might be some sort of a solution to at least get a broad spectrum antibiotic in them before you ship them out. Knowing that with every hour that we wait for antibiotics, the chance of mortality increases and the chance of transitioning into septic shock increases significantly. But yeah, I see that running 30 minutes to the closest lab. I've heard that so many times, and it's just, it's a real life barrier that I wish I had a solution for. I think that just has to be incorporated in your policy, that we can't do stat lactase, but also maybe even at least educating the staff that if you suspect sepsis, and we have 2 SIRS and we think there's an infection and we need a lactate and there's nobody to run it for 30 minutes, this is probably the opposite of what we want to do, but maybe it is time to transfer the patient to the emergency department, knowing that they are starting to screen positive and sepsis has an insidious progression. We've talked about this a lot. Obviously from the quality perspective, we want to decrease hospital utilization, decrease admissions and readmissions, but we have seen when hospitals and nursing homes start successfully identifying septic patients, the numbers technically go the other way, because we're identifying and we're transferring. So again, it's just going to be based on you, your medical director, and your team, and maybe your corporate office, if you have one, on your protocol as a patient starts to advance through the algorithm.
Josh, you made me think of a point. Of course, yeah, the earlier we identify possible sepsis, then the more success we have, for, of course, for the patient, and then for not having to send them out. I've worked with, or like you mentioned too, the electronic health record, so that, that the assessment is triggered, that a sepsis assessment is triggered. So there it is in front of the nurse's face, so that they have to complete it for when it's triggered. But of course, training, has to go behind that assessment. And what are your thoughts on training for, maybe not necessarily sepsis for your support staff as in nursing assistants, but we all know that who's the eyes and ears mostly, right? For your patients is those nursing assistants. Do you find that homes that have successful sepsis protocols have involved their nursing assistants also?
Absolutely. I mean, your nursing assistants are going to know if probably a little bit better if a resident is not themselves today. And that can be, it's not on the tool, but that's a change in condition. We know that. And, some facilities have chosen under a change in condition assessment just to put the sepsis assessment as part of that change in condition. We're going to get a set of vitals anyway with any change in condition assessment. And then, of course, doing some sort of an education with the nursing assistants about the vital sign parameters, I think is probably most important, as well as, are they outside of their baseline? Is she acting different? Is he not himself? Please alert us. And I think that's probably basic, that most nursing assistants, already do that. And I think it's just giving that rationale that, these infections can escalate quickly. But other solutions, more costly solutions, is some facilities have integrated this into their electronic medical record, and they built little like clinical alerts in the background that says, oh, the nursing assistant entered the vitals, flag, temp is high, heart rate's high, possible sepsis, please complete sepsis assessment. So that also, I don't know if it's built in point click care. I think that's like one of the ones that a lot of our nursing homes use. We'd have to check with the vendor, but that is another option, is to use HIT as a clinical decision support tool. Oh, I see it's an option for those who use Matrix.
Yeah.
Cool. Yeah. And some places have nursing assistants enter the vitals, some don't.
Right.
So it'll be based definitely on your processes and how you want them to communicate that to their nurse.
It looks like we do have the survey for today's presentation was just dropped in chat. So please, when you get a chance before you leave here today, if you could fill that out. As we're thinking about other questions for Josh, I do want to just go back just for a second to the polling question that was asked of you earlier. It was about what kind of future presentations would you like? And if you, just to jog your memory, they were on dementia, QAPI, infection control, staff training and turnover, MDS or NHSN, and your environmental or multidisciplinary additional staff, dietary, laundry maintenance, anything, those type of topics. I said all of those because what I would like for everyone to do for me is if you could just drop in just one suggestion out of all of those topics, dementia, QAPI, infection control, staff, turnover, MDS, or training, if you could just drop in one suggestion for a possible presentation for our 2023 2023, what's the word I'm looking for here, a schedule, that would be great. Just one. Even if you think it maybe we've repeated it before or we've done it before, that's okay. Because if you're putting it in there again, it looks like maybe we need to revisit it again. Just one. Josh, do you have any other comments or tips or anything else that you think the audience would benefit our audience today to hear?
No, I mean, I think the biggest thing really is getting buy-in from your medical director, especially if you have a really engaged one, and seeing if they are able to kind of take the physician lead on this, or the clinical lead, and really, having them be your advocate for what we should and shouldn't do, and looking at all your processes. I mean, every place is so unique that it isn't a one-size-fits-all package. And of course, including your infection control person, your DON, your quality people, all of that. But that's the most success we've seen has been physician and leader driven, and it's difficult. I've done this a lot more in the hospital setting than the SNF setting, but if you say we're going to do this and this is going to be a protocol, and you don't get medical director buy-in, it results in a lot of pushback. So yeah, that would be my first tip, is invite that medical director to the first meeting or meet with them before and get their buy-in.
Yeah, actually, Josh, that's a great tip. I know sometimes that's also an issue with antibiotic stewardship. So yeah, great tip for sure. I just wanted to thank those of you that have been putting in their comments about what they would like to see for future programming. I really do appreciate that.
And I echo those things, Kim. We don't have any new questions. I'm not thinking we do. I think we're just getting comments on what people would like to hear about, correct? Just want to advance to the next slide. Just a reminder to register again for the 2023 Roundtable series. You do have to re-register for the sessions in 2023 to get the calendar invites. Again, they'll be the second and fourth Wednesdays. So we'll see you next on January 11th, 2023. And then here is, you can use this QR code to register. And also, if you think of things after our session today, you can use the evaluation link, of course, but also we've got the Connect link up here. You can use the QR code again to use this, or there is a link here right here on the slide. We'd love to have you on Connect. If you haven't already joined Connect, it's a great place to share and network with each other. And so I just wanted to put that out there too. Any other comments or questions before we wrap up for today? If there aren't, I just want to again thank Josh. Great presentation. I want to thank all of you for attending today and also for attending our sessions throughout 2022. We look forward to seeing you all again in 2023. I want to wish everyone a happy holiday, and we can wrap it up for today. Thank you all.